The video head impulse test, or vHIT, was introduced several years ago as a novel test of vestibular function. It promised to provide a quick and independent test of all 6 semicircular canals and their neural pathways. Recently, commercial devices have become available for vHIT, and with that, the test has gained more widespread clinical use. This 4-part video series provides the information that's needed to perform and interpret the video head impulse test. If you're not familiar with performing vHIT, please see this video for a demonstration first. Most of the information in this presentation is based on the work of Halmagyi, Korthoys, and their colleagues in University of Sydney. For a complete list of references and other useful information, check out headimpulse.com. Part 1 of these video series is an introduction to vHIT and a review of its underlying physiology. Head impulse testing was first described by Halmagyi and Korthoys in 1988 as a bedside test of the vestibular ocular reflex, or VOR. It's a simple test where the patient is asked to look at the stationary target, usually the examiner's nose, and the head is rotated to the right or to the left using unexpected, small amplitude, high velocity, high acceleration head movements. As we'll see throughout these presentations, the success of both the bedside test and vHIT depends on generating precise head movements, so it's worth repeating that the direction, timing, and intensity of head impulses should be randomized, and small amplitude, high velocity, high acceleration head movements should be used. In general, normal individuals can maintain a steady gaze during head impulses without generating any extraneous eye movements. But patients with deficient semicircular canal or nerve function can't keep up with high-velocity head movements during head impulses toward the damaged side. As a result, the eyes fall short of the target, and the patient has to generate catch-up or refixation saccades to reset the eyes back on the target. Initially, the procedure was described for testing the lateral or horizontal canals, but the head movements can be performed in the plane of anterior or posterior canal pairs, which allows independent evaluation of all 6 semicircular canals. First, let us review the direction of head movements that's necessary to evaluate each semicircular canal. For testing the lateral canal pairs, the head is rotated 30 degrees downward in the vertical plane, and head impulses are delivered in the horizontal plane. In this case, head impulses to the right are primarily a test of the right lateral canal, and head impulses to the left are primarily a test of the left lateral canal. For the right anterior and left posterior canal pairs, or RALP, the head is rotated 45 degrees to the left in the horizontal plane, and the head impulses are delivered in the vertical plane. For RALP, downward head impulses are primarily a test of the anterior canal, in this case right, and upward head impulses are primarily a test of the posterior canal, in this case left. For the left anterior and right posterior canal pairs, or LARP, the head is rotated 45 degrees to the right in the horizontal plane, and the head impulses are again delivered in the vertical plane. Again, downward head impulses are primarily a test of the anterior canal, in this case left, and upward head impulses are primarily a test of the posterior canal, in this case right. In practice, for lateral testing, the head is usually moved downward much less than 30 degrees to avoid moving the eyes too far up in the socket. In fact, most clinicians do not move the head down at all. This has a minimal effect on the intensity of the stimulus that's delivered to the lateral canals. On the other hand, for RALP and LARP, the head turned to the right or left should be close to 45 degrees, at least no less than 35 degrees. The reason is that smaller head turns can provoke responses from all 4 vertical canals instead of limiting them to just 2. We will discuss the recommended procedures to do vertical head impulse testing safely and efficiently in part 3 of these video series. For the lateral canal testing, one should look for horizontal catch-up saccades, and for RALP and LARP, one should look for vertical catch-up saccades. Although the bedside test is useful, it turns out that it has a major limitation. Halmagyi, Courtois, and their associates discovered that some patients are able to make saccades that are not visible to the naked eye. They call these saccades covert saccades to differentiate them from the overt saccades that are visible without any additional equipment. The University of Sydney group made this discovery using the scleral search coil method. This is a highly accurate method for measuring fast three-dimensional eye movements. Unfortunately, the search coil method is not suitable for routine clinical testing because it often involves anesthetizing the cornea to place contact lenses that contain small coils with wires attached to them. As the high-speed miniature cameras became more available, vHIT was eventually developed. ICS Impulse is a commercial vHIT device that's based on the prototype developed in association with Halmagyi, Courtois, and their associates. It uses a high-speed, high-resolution camera to measure the eye movements and provide a quantitative measure of the VOR function. Three-dimensional head movements are also measured using sensors embedded in the goggle. The device monitors the clinician's ability to deliver appropriate head impulses and provides feedback to improve performance. The head impulse test relies on the fact that there is a neural asymmetry between the excitatory and inhibitory responses of the canals. For example, let's select one semicircular canal, in this case right lateral canal, and look at the behavior of one of the hair cells in this canal. It is important to recognize that although we will be discussing the responses of the lateral canals, the same principles apply to the anterior and posterior canals. When the head is at rest, each hair cell still provides pulses of neural activity at about 70 to 100 spikes per second to the central nervous system. If the hair cells bend in one direction, it causes excitation and the neural firing can increase up to 400 spikes per second. If the hair cells bend in the opposite direction, it causes inhibition and the neural firing decreases. But in the case of inhibition, the neural firing can't drop below zero, which causes an asymmetry between the excitatory and inhibitory responses of the hair cells. This asymmetry is the basis of the well-known Ewald's second and third laws, which stresses the difference between the dynamic ranges of the excitatory versus inhibitory responses. The asymmetry between excitatory and inhibitory responses affects how the semicircular canals respond to movements in different directions. For example, head impulses to the right cause the neural firing from the right labyrinth to increase rapidly from the baseline and to return to it very quickly. The change in the neural firing for fast head movements, like head impulses, is proportional to the head velocity. As a result, this signal can be fed directly to the oculomotor system to generate VOR eye movements. On the other hand, head impulses away from the canal, in this case to the left, cause neural firing from the right labyrinth to decrease from the baseline and become saturated at 0 spikes per second. As a result, the right labyrinth has lost the ability to measure the head velocity accurately for the grayed out area. This would have been a problem if we had only one labyrinth. But fortunately, for every semicircular canal on one side, there's a synergetic pair on the other side where the neural responses are completely mirror images of each other. Let's examine what happens when the head is moved to the right at velocities that are fast, but not as fast as head impulses. So we're talking about head velocities just below 100 degrees per second. This type of head movement is not fast enough to cause saturation of the inhibitory response. In this case, the excitatory response from the right and inhibitory response from the left are proportional to the head velocity. The eye movements are driven by the difference between the excitatory and inhibitory responses, and this neural command itself is proportional to the head velocity. That means the eye velocity mimics the head velocity in the opposite direction. That's exactly what VOR is designed to do. to keep our eyes on the target during head movements. It's important to recognize that all of these activities occur at the brainstem level without any involvement from the higher cortical levels. As a result, VOR eye movements have a very short latency, which makes them considerably faster than other types of eye movements that require higher level cortical involvement. We know that the head and VOR eye movements are in opposite directions, but for display purposes we can invert the eye velocity so both the head and eye velocities are in the same direction. We can also do the same with the eye position in the upper tracing. The response for this type of head movement can be quantified by comparing the head and eye movements. For this particular example, the VOR gain, which is defined as the ratio of eye versus head movements, is close to 1. Now what happens if the head is moved to the right using a head impulse? The change in the excitatory neural firing from the right side is proportional to the head velocity, but the inhibitory neural response from the left labyrinth and the difference between the two are no longer proportional to the head velocity. The resulting eye velocity is not exactly equal to the head velocity, but it's close, especially because at least one labyrinth accurately characterizes the head movements. So despite the asymmetry between excitatory and inhibitory responses, the resulting eye movements remain symmetrical for right-left head impulses. Finally, the VOR gain is again close to 1, but decreases slightly with increasing head velocity. If one of the labyrinths is damaged completely, let's assume the right labyrinth. In the acute phase of the lesion, the patient experiences vertigo and has a spontaneous nystagmus because the tonic neural activity that was present before is no longer there. Over time, this tonic activity is restored through the vestibular compensation process, but the patient still exhibits dynamic symptoms. From here on, we will ignore the loss of tonic neural activity and assume that it has been restored. Instead, we will concentrate on the dynamic effects of the lesion. For a head impulse toward the side of lesion, the excitatory neural activity from the right side that was proportional to the head velocity before is no longer present, and the inhibitory neural activity from the opposite side saturates quickly. The resulting command to the oculomotor system no longer resembles the head velocity, and the VOR eye velocities are much smaller than the velocity of the head impulses. This is reflected in the VOR gain that's significantly less than 1 and decreases rapidly with increasing head velocity. This is the basis of the eyes falling behind the target during head impulses toward the side of lesion, which necessitates a catch-up saccade to reset the eyes on the target. We will discuss the catch-up saccades shortly, but first let's see what happens for head impulses away from the side of lesion. For the head impulses to the left, the excitatory neural response from the left labyrinth resembles the head velocity, but the inhibitory response from the right side is missing. As a result, the neural command to the oculomotor system and the resulting eye velocity is proportional to the head velocity, but it's smaller. This means, contrary to what one might assume, the head impulse responses away from the side of lesion are not normal. In fact, it's possible to have catch-up saccades during head impulses away from the side of lesion, especially if the damage is substantial. The major difference between the responses toward and away from the side of lesion is that, first, for head impulses toward the side of lesion, the VOR gain is significantly smaller and it decreases far more rapidly with increasing head velocity. Second, for head impulses away from the side of lesion, the VOR eye velocity is smaller, but is still proportional to the head velocity. Contrast that with VOR eye velocities toward the side of lesion that do not resemble the head velocity at all. Now let's look at the properties of the catch-up saccades. Here the VOR eye position and eye velocity are shown along with the head movements for head impulses toward the side of lesion. At the end of the head movement, signified here by the red line, The VOR eye movements have failed to position the eyes on the target. The difference between head and eye positions triggers a catch-up saccade, but the saccade does not occur immediately because of the initiation time that's required for such saccades. The time that it takes for a catch-up saccade to appear is approximately 100 milliseconds. This is considerably more than the VOR latency because of the cortical involvement. The catch-up saccades, shown here with solid red lines, are represented in the position tracings by a quick repositioning of the eyes. On the velocity tracings, the catch-up saccades are represented by a narrow spike. When the catch-up saccades occur after head impulses, they're called overt saccades. Overt saccades are visible and can be detected by an experienced examiner during the bedside test without any additional equipment. If after a period of time the patient realizes that at the end of the head movement their eyes will not be positioned on the target, it makes sense not to wait for the end of the head movement. In other words, as soon as a difference between head and eye velocities is detected, the patient can initiate the saccade. Now, if the time to initiate the saccade is short, then the catch-up saccades will occur while the head is still in motion. Catch-up saccades that occur during head impulses are called covert saccades because they are virtually impossible to detect with the naked eye. Covert saccades are the main reason that one needs video recording of eye movements during head impulses. An important question comes up regarding catch-up saccades. Why do some patients generate covert saccades while others do not? To answer this question, one has to be familiar with the concept of saccadic latency. For catch-up saccades, both overt and covert, the saccadic latency is defined as the time difference between the onset of the head movement until the occurrence of the saccade. It consists of two components. First, the time that it takes to predict the difference between head and eye positions, and second, the time to initiate the saccade. For covert saccades, both these times have to be short. The time to initiate the saccade is usually fixed for most patients and is around 100 milliseconds. So earlier prediction of the head and eye position difference is mainly responsible for generating covert saccades. Some have attributed the presence of covert saccades to the process of dynamic compensation, which means dynamic compensation is directly related to how quickly we can detect the head-eye movement differences. If that turns out to be true, then vHIT is even more useful than initially assumed because it not only can tell us about the site of lesion, but also about the level of compensation. This view is supported by the fact that most patients have overt saccades at the onset of the lesion, but later on the saccades are converted to covert saccades. But there are still a number of questions about this view. For example, some patients generate covert saccades within hours after the onset of the lesion. That seems to be too short of a time to achieve dynamic compensation. Also, some patients do not generate covert saccades regardless of how much time elapses since the onset of the lesion. Do these patients never compensate dynamically, or is there something else? Following the same line of reasoning as before, these patients either do not predict the difference between the head and eye positions early enough, or they may have longer saccade initiation time, which precludes them from having covert saccades regardless of the compensation level. So for the time being, the association between the presence of covert saccades and the level of compensation is an interesting concept, but it's not fully resolved yet. Recall that appropriate head impulses consist of unpredictable head movements with randomized direction, timing, and velocity. So at least theoretically, the patient is unlikely to predict the final position of the eyes during head impulses. and should not be able to consistently reposition the eyes on the target precisely. Instead, in most cases, covert saccades bring the eyes close to the target but do not reach it, which means a secondary saccade is needed to position the eyes on the target. The secondary saccade is usually smaller and almost always is an overt saccade because of the saccadic latencies. One may wonder why these saccades are not detected during the bedside testing. The main reason is that the amplitude of these saccades are too small to be seen. Now let's look at animations of eye movements for different patients. It looks like this patient has overt saccades during head impulses to the right, but no saccades are observed for head impulses to the left. This is a very specific finding that indicates a lesion involving the right lateral canal or its afferent neural pathway to the superior portion of the vestibular nerve. The second patient does not have any observable saccades during head impulses. The bedside test in this patient would be considered unremarkable. However, this patient actually has covert saccades. The only way to see them is to play the video frame by frame. Even then, one has to pay attention to detect the covert saccades. This is the reason that eye movements have to be recorded in vHIT for evaluation of the head impulse test results. This concludes the first part of the video presentation on vHIT. Please check out the second part, which will concentrate on the interpretation of the vHIT results.